Some months ago, as Republican leaders were preoccupied with another unsuccessful attempt to replace Obamacare, a senior Trump administration official issued a warning about a different major medical program, Medicare. The official, Indiana's Seema Verma, administrator of the Centers for Medicare and Medicaid Services, wrote in the Wall Street Journal that Medicare was facing a fiscal crisis. She announced that she was asking the agency's Innovation Center for ideas to address it, and that part of the answer was to give consumers incentives to be cost-conscious. This has some Democrats worried that she's trying to move Medicare towards something called premium support, which would be a huge change for consumers. Premium support is the topic of this week's Healthcare Triage. Special thanks to Austin Fracht, from whose Upshot column this episode was adapted. Before we get into the pros and cons, what's the fiscal crisis? According to projections from this year's Medicare Trustees Report, the fund that pays for Medicare finance hospital care will be depleted in 12 years, and care for other services will consume an ever larger share of the economy and federal revenue. Citing trends like those, Republicans included the outlines of a Medicare premium support plan in the House of Representatives' fiscal year 2018 budget resolution, as they did in several prior ones. In broad terms, premium support means the government pays a contribution towards premiums and the beneficiaries pay the rest. In a sense, today's Medicare program already has such a structure. For either the traditional program or a private Medicare Advantage plan, the government pays a preset premium stipend, alternatively called a subsidy, credit, or voucher, that varies across these two parts of the program. In all cases, stipends grow at the rate of healthcare costs. If Medicare already has a form of premium support model, what's all the fuss about? The important difference is in how stipend levels are set. Today's stipends are not driven by the market, but are set according to legislatively established formulas. But the type of premium support Medicare reformers usually advocate, what people generally mean when they use the term, would use market signals to set stipend levels. It's possible that premium support could increase the efficiency of Medicare. That efficiency could push the hospital trust fund depletion date further into the future and reduce the financial burden on future generations. Premium support models take many forms, but there are two crucial variables. One is how the stipend levels are set, which determines how much of a beneficiary's own money they need to contribute. The other key feature of premium support is how much the stipend grows over time. Both aspects are hotly debated. In some versions of premium support, the stipend level will grow more slowly than healthcare costs, forcing people to pay more and more out of pocket over time to purchase coverage. In other versions, the stipend level will grow at the same rate as healthcare costs, so beneficiaries would continue to pay about the same share of their own money for health insurance. Most premium support approaches would retain traditional Medicare, though its fate would be uncertain, which is a source of controversy. Timothy McBride, a health economist with Washington University in St. Louis, has said, and I'm quoting, "A lot rides on how the government support level differentially impacts the cost to beneficiaries of private plans versus traditional Medicare. If traditional Medicare is disadvantaged, that would hit rural beneficiaries harder, because a larger share of rural America relies on the traditional program than do urban Americans." As a report last month from the Congressional Budget Office reveals, how much premium support could save the government varies considerably depending on how stipend levels are established. Across the variations the CBO examined, Medicare spending could fall by as much as 9% or about as little as 0.5%. But premiums could rise, including the premium for traditional Medicare. Under one projection, the CBO estimates traditional Medicare's premium could double. In all the scenarios the CBO analyzed, stipend levels would be based on bids for Medicare Advantage plans and traditional Medicare that reflect the cost to cover a person for standard Medicare services. Stipend levels would keep pace with overall healthcare costs, but they could still be lower than what many Medicare beneficiaries receive today. For example, tying the stipend to the second lowest bid and requiring all Medicare beneficiaries to be subject to that new lower level would save $419 billion with a B dollars over 2022 to 2026, the CBO estimated. Tying it to the average bid, or requiring only new beneficiaries to be subject to the new stipend, would save less. In either case, people would have access to plans that don't cost more than today's. But those who opted for more expensive plans because they offer more benefits, or the traditional program because it covers any doctor willing to accept Medicare patients, would pay more out of pocket. Consequently, more patients would opt for cheaper private plans, and fewer would choose traditional Medicare. This worries some health policy experts. Traditional Medicare has led the way in reforming the healthcare system in the past, and it's done a pretty good job in controlling costs relative to private insurance. But if too many people leave the program, it can't work as well. Exactly how much more people would pay depends not only on the plans they select, but also on where they live. In some markets, many plans, including the traditional program, might charge premiums close to the second lowest bid. In others, plans that many beneficiaries may want might cost a lot more. In the premium support debate, there's a fundamental lesson. It's conceptually simple to reduce federal spending on healthcare, but it's very hard to do so in a way that doesn't increase costs for at least some consumers. To actually reduce total, not just federal, healthcare spending for everyone, one has to overhaul how healthcare is delivered, not just how it's paid for. That's much harder. Hey, do you like this show? Maybe consider subscribing to it, or like the video. Moreover, we do lots of videos on topics YouTube doesn't really love to sell to advertisers, and we don't care because content matters more than advertising revenue. But any support that we can get to help keep the show going is great, and a good way to do that is through Patreon.com, a subscription service that allows you, the viewer, to support the show through a monthly donation. You can go to patreon.com/healthcaretriage to check that out. Speaking of thanking people, we'd especially like to thank our Surgeon Admiral Sam and research associates Joe Sevitz, Joshua Crow, and Carlos Galiergos. And while we're saying thanks about stuff, consider picking up some Healthcare Triage merch. It's great for holiday gifts, and I've got my new book out, The Bad Food Bible. Really appreciate it if you buy a copy.